bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities.
All right, hello everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And today's webinar is titled Serving Youth Receiving Child Welfare Services, the Maltreatment and Adolescent Pathways Research Study. And as always, we have an excellent presentation. But all right, we're once again excited to bring some colleagues that we at CAFC connected with through the CYCC network initially years ago. That's the Children and Youth in Challenging Contexts Network. And that network has provided a great opportunity for us to access information and research related to child and youth mental health and well-being. And it's really a great opportunity to share that information with our community. We've got three great presenters today. And first, it will be Dr. Weckerle, who's a name probably familiar to many as she's presented a number of times on our webinars. And Dr. Weckerle is an associate professor in pediatrics and an associate member of the Offord Centre for Child Studies at McMaster University in Hamilton, Ontario. And Dr. Weckerle's research areas are broadly in the areas of parenting and prevention of family violence. And following Dr. Weckerle will be Lise Milne. And she is a fifth-year PhD student, social work student at McGill University. And over the past 8 years, she's worked at the McGill University Center for Research on Children and Families on several projects, including evidence-based management in child welfare, building research capacity with First Nations and mainstream youth protection services in Quebec, and attachment self-regulation and competency. And then following Lise will be Dr. Sherry Stewart, who is a professor in the departments of psychiatry, psychology, and community health and epidemiology at Dalhousie University in Halifax, Nova Scotia. And she's also a licensed clinical psychologist in the province. She's well known for her research on psychological factors contributing to emotional disorders and substance misuse, the comorbidity of mental health and addictive disorders, and pathological gambling. So before we get started, we are going to do a few polls just to see how familiar the audience is or what some thoughts are about some of the content that we're going to present today. So the first question is, how highly do you value trauma-informed care? And this is just your opportunity to go up and make your selection by clicking on the screen. Just click the little bubble beside your answer choice, and we'll just see what people think about trauma-informed care. And hopefully many of you are familiar with it, since we did have a webinar presentation a number of years ago from some colleagues from the IWK Health Centre about trauma-informed care. So that should not be a new term, hopefully. All right, so we're going to close that off. And some of these we're going to show the answers near the end, but we're not going to turn the answers around right now. The next question is just asking, for the agency that you are part of or representing or work at, does your agency or program screen for victimization? And we'll turn the answers around for this one so our presenters can see what the results are of this one. So we can see that 33% are say yes, they do screen for victimization, 25% no, and 42% are unsure. All right, and the next poll, the last one we're going to do for now, is, does your agency or program screen for emotional trauma? Let's see what people thought. 64% say yes, they do screen for emotional trauma. 18% said no, and 18% unsure. So we're going to hand the virtual podium over to Dr. Weckerle to kick this off and introduce the next part of the program, which is going to be a short video, but we'll just hand it over to Dr. Weckerle to introduce this short video that we're going to show. Over to you, Dr. Weckerle.
Thanks very much, Doug, and thanks for those introductions, and good morning, everyone. Thank you for joining, and thank you in advance for live tweeting. I'm on the Twitter, ready to talk with you on that channel. And to start off, we're going to show a 3-minute video that overviews some of the findings from the Maltreatment and Adolescent Pathways study. a study of child welfare involved youth, adolescents in the ages of 14 to 17. We were pleased that we were an awardee in this competition from the CHRI HD and CYH Institute. So let's have a look at this video. Hope you enjoy it.
Adolescence is a critical period of development for the adolescent brain and their behaviors. It is a window of expected risk-taking. For youth living in adverse contexts, that can become taking risks with their physical and mental health. The Ontario provincial and Canadian federal government supported a research study to learn from youth. The Maltreatment and Adolescent Pathways, MAP, research team's goal was to better understand how youth with abuse and neglect experiences while growing up were doing as they were receiving governmental service supports like child welfare. To give these youth a voice, recognizing the importance of their lived experience to our body of knowledge on adolescent health, and to guide policymakers and service organizations on how they can provide a better service to needs match. The MAP study has generated several important findings. First, several youth experience violence in their dating relationships. Over 30% of teens receiving child protection services reported experiencing dating violence, from verbally abusive comments to pushing, shoving, kicking, hitting, to sexual coercion. About 15% of teens showed persistent dating violence over a 3-year period, from about age 15 to 18. This suggests that adolescence is an important window of opportunity to teach about new ways of relating. Second, youth who had received services over years and were living out of their family of origin home reported less dating violence in their lives. Services and role models for healthy relating seem to make a difference. An interesting question is what else can make for more resilience? The MAP study found that youth with higher self-compassion had lower dating violence, and also fewer health risk behaviors like suicidal thinking, substance use problems, and depression or anxious moods. When you can support youth to see their abuse or neglect as not their fault, their mistakes as part of a learning process, to uplift rather than put down, and take a big picture view of life, there are many positives. For MAP study youth, positive self-talk, creating a positive social network, feeling connected, and making healthy dating choices are all part of doing well. Adolescence is a critical window of opportunity. MAP research shows that the most important relationships are being kind to others, and especially yourself. To learn more about our resilience research, email us, visit us online, and follow us on Twitter.
All right, so we're now just going to hand the screen over to you for the rest of the presentation.
Okay, what you just saw was an overview of the MAP study and how we're trying to look at both impairment as well as resilience aspects, and to try and translate that into practical strategies. So the link is on this slide. The slides will be available to you, and you can distribute that broadly. That's an open access product. So the Maltreatment and Adolescent Pathways research study, we want to let you know that this is also tied to our Resilience in Youth efforts, and that's on YouTube, Twitter, and Instagram. And you'll find open access articles on topics like child welfare and resilience in the International Journal of Child and Adolescent Resilience at the website www.in-car.ca. It takes more than a village to track and find youth that are mobile and move residences frequently. And we had a wonderful advisory board and multidisciplinary team. And today we're going to be talking to some great collaborating scientists. And like to acknowledge the CHR team grant on boys and men's health, which provides us funds to focus on males with sexual victimization. So why do the MAP research study? Well, the prevalence of mental health issues among youth of various statuses in child welfare is relatively low. There's more focus on youth who are in foster care or who are in Canada, in Ontario Crown wards where parental rights were terminated, and the government is their, the corporate parent. So the MAP was the first Canadian multi-method study done, and we have self-report, we have a number of constructs, we have IQ testing, we have neurocognitive testing, so it's we have caseworker reports, so we have quite a range of data types in this data set, so it's a rich data set, and we were able to test these youth every 6 months over a 2 to 3 year period, which for a child welfare sample and active testing is a challenge to achieve. We were able to randomly select from the open caseloads, and these were refreshed every 6 months. So the youth that are in our study have been in child welfare for at least 6 months, because if a case was open and closed in under 6 months, by the time we would get to them, they would not be active in the system. We included all types of youth, as mentioned, and we didn't tap from those youth who were on the adoption caseloads or set to be on the adoption caseloads. But we did tap youth who were receiving child welfare services in their homes and those who were out of home, either in independent living, group home, or foster care. We didn't sample the most, the youth who were having the most troubles, the youth who were either in hospital, in detention, in residential crisis, or suicidal at the time of study entry. And we did utilize repeated assessments of their victimization. So this would include all forms of child maltreatment, physical, sexual, emotional abuse, and neglect, as well as other traumatic events, such as bullying, etc. And for this sort of a study, we were able to obtain a pretty large sample of youth who've tested at intake at 561. And one of the theoretical models we work with is that the bridge variable between child maltreatment experiences and the adolescent having challenges is that it may be related to trauma symptoms, emotional problems that create a higher sense of emotional reactivity to other stressors they encounter, and certainly to any trauma related stressors. So for instance, if they were assaulted in the basement and they had an option to live in a basement apartment, that wouldn't be a really good fit for the youth. So we have trauma events and trauma responses. So the maltreatment and other adverse events are trauma events, and the youth do or do not have trauma responses. And with the idea that kids are doers, many times these trauma responses are seen as acting out behaviors. And for the teen, this may be experienced, for instance, if you have a youth in any sort of service in a hospital, as avoidance and resistance behaviors, or what would be considered protest or testing behaviors. These, in addition to behaviors directed toward themselves, like self-harm, but these kind of acting out behaviors can be seen as just the youth is a problem and they're just difficult to manage, rather than oh, gee, is there something in the background here that is related to what we're seeing and how they can engage with healthcare practitioners? So in particular, you have conflict with authority, sexual acting out, and eating problems. What does that mean practically for services? The consideration of a trauma-informed approach, which is wanting to ensure physical, emotional, behavioral safety in the CanMeds, our health advocate role, and to be creating opportunities for resilience. So whether the youth comes in for instance, nutritional counseling, and they're given some ideas of healthy snacks, is how to take that prescription, if you will, to the youth and break it down in ways that they can see their past history of successes and build on resilience to be better adherers of medication, or be better at sticking to new interventions, small I and big I. And also the experience of choice and control, and that means checking in with youth preferences and engagement. So we understand now that trauma experiences are high-impact events that are typically emotionally difficult to deal with. And in the adolescent time, it's a time of transition, as we know, in terms of wanting to fit in, figuring out what your identity is, getting more abstract thinking and conceptual thinking abilities, and so forth. And so there are challenges given the maltreatment experiences, which are relationship-based usually, and now the youth are especially having this developmental task of forming their own relationship networks. And what our message is in terms of resilience is that, as you saw from the video, it's really a daily resilience practice around how a youth, what their mindset, what sort of behaviors they can engage in, with the goals of reducing their everyday experience or perceived stress experiences. So it might be shifting a mindset, increasing or solidifying their everyday resilience practices. And we know sleep is a significant issue, so protecting sleep. And the MAP youth the majority reported sleep onset problems. Facilitating that social connectedness, and self-compassion is sort of a newer concept as presented in the video, which is really having a kind approach towards your own failures and faults, not getting over-focused on them, seeing them in the bigger picture. And of course, exercise and fitness, we know, are effective for things, for emotional symptoms. So from the MAP, what do we know, and why are we focusing on traumatic stress symptoms? Well, various emotional symptoms were measured in the trauma symptom range of symptoms, and these emotional symptoms mediated in the prediction of maltreatment and adolescent sleep quality in the MAP sample between maltreatment, adolescent use, and alcohol use and problems with use, alcohol problems in Indigenous youth, and adolescent dating violence. So what we see is that there's a suggestion here that if you target trauma symptoms, then you may be actually targeting all these diverse regulation and functioning challenges, unhealthy coping strategies for youth. So that's really the key message when you find a consistent pattern of mediators. And we knew from looking at the symptoms that females were, reporting symptoms more so like crying, and males were reporting symptoms more so like preoccupation with sexual thoughts they were recognizing that those were intrusive. So overall, child welfare youth report higher distress. They see doctors more often, and they're more often on medication for anxiety and depression than non-child welfare youth. And that comes from the Ontario Student Drug Use and Health Survey data. And to show a bit of a connection, when we look at the parent's own history of maltreatment, parenting stress is the mediator in terms of their own history and their capacity for sensitivity to the infant in observed interactions. So what we're seeing as the core issue being, youth, because of their maltreatment history, are going to be vulnerable to have a higher reactivity to stressors generally and to maltreatment reference stressors in particular, and they tend to destabilize behaviors. And so they look like, this is when you say the youth is very challenging behaviorally or in the more severe because they look out of control. And so we need to target and be sensitive to ongoing violence and traumatic events. So not only the maltreatment that they experienced earlier in childhood, but what might be happening now for them, if that's bullying, and recognize that that's sort of an ongoing or a re-victimization conceptualization, and to directly support their emotion regulation strategies from simple to more complex. If you're taking a sip of cold water, to deep breathing, to engaging your thinking about, an event as not devastating but disappointing, for instance, and to work up replacing these non-optimal or unhealthy behavioral acting out to behaviorally acting out their resilience. And some of the more recent work from our teams on Indigenous youth supports the cultural engagement, connectedness, enhancing their competence and communication. Because a lot of times youth don't have that emotion literacy, those words to actually use. And so that may be something that that is teachable and maybe something that's relevant. And in one of the studies done along with Dr. Sherry Stewart, resilience was protective against one aspect of trauma symptoms, which is re-experiencing the trauma in an Indigenous youth sample. So some simple actions really to be mindful. Do we know, no matter what service entry door we are in, do we know what youth are coping with? We can ask, we can advise, we can assess, we can assist, and we can arrange for supports and resources. And the kids' help phone is always a valuable 24/7 resource, and they have a Bro Talk, which is specific to male youth and young adults service. So the idea is kind of having in your mind what's going on for you rather than thinking what's wrong with you. And to think about whenever for example, whenever you're discussing a case in a team, to be able to start with what are the positives and ensure that those kind of positives get conveyed to the youth, because for these youth, there's an overloading and an over-practice with negatives, and there's an under-experiencing and an under-practice with positives, so you can't really give enough positives in a day, and I think that likely applies to people in general. So thank you for your attention to my piece, and we move over to Lise Milne.
All right, thank you, Dr. Weckerle. Great intro to the topic here. And this is before we move on to Lise, just my chance to remind the audience, if you do have any questions, don't hesitate to type them in, and we'll get to them at the next break. So we'll now move on with Lise Milne.
Thank you, Doug, and thank you very much, Christine. I'm really pleased to be a part of this webinar on this very vulnerable and resilient population of youth involved with child welfare. I'll be talking about youth in one of the highest levels of care in the child protection system, which are youth in group care. So this will include youth who've been placed either in community group homes, which are sort of at the lower end of the care spectrum, as well as kids in sort of the higher levels of care, which are residential care units. So the objective of my research here as a PhD student doing my dissertation research is to present findings from the MAP study, and as I mentioned, to focus specifically on kids in group care on their self-reported maltreatment experiences, so the potentially traumatic events that they've experienced, their trauma symptoms or mental health symptoms, as well as some of the resilience that they demonstrate, so in particular their interpersonal competencies. And these youth have been of great interest to me. As Doug mentioned, I was a frontline protection worker in the 90s and the 2000s, so for about 15 years working in Manitoba and Quebec, both as a frontline worker, supervisor, and a trainer. And I got to witness firsthand our tendency to really respond to the presenting behaviors that Christine was talking about, so these sort of acting out behaviors, which really basically hide the underlying events that these youth have experienced, and understanding the potentially traumatic events these youth have experienced from their perspective. So hearing from the youth themselves is really important if we're to put into context their current behaviors and mental health symptoms, as well as to figure out how to bolster their resilience, which we know is dynamic and can change. So this is important for all child welfare and health professionals across a variety of systems who will inevitably work with these youth and or their parents or the infants and children that may very well grow up to be youth like these. So regards to these youth, there's so much crossover amongst the health, social services, child welfare, and criminal justice systems that I think this is relevant for the wider audience. So few assessment procedures in child protection exist, despite the fact that there's a variety of mental health organizations and trauma networks that have really been pushing for this. And so this is a kind of a standardized way when, we ask the question initially when kids come are involved in your organization, is there any screening that takes place? And in particular in child protection, there's often a very basic screening around the presenting problems, but we don't always delve deeper into their past experiences. And, in order for us to learn more about the children and youth with whom we work and to provide appropriate services, this is really necessary information. If not, we're really put in the precarious position of relying solely on official incident statistics. And we know that these severely underestimate the true experiences of maltreatment. So we know that research to date has demonstrated that youth in group care have experienced really high levels of maltreatment, often experiencing many different forms of maltreatment, with some considered polyvictimized. And if some of you are familiar with a term used by Finkelhor, this describes 4+ experiences of maltreatment or trauma. In his studies, it's also exposure to other events such as community violence, war, bullying, etc. So as I mentioned, child protection does tend to respond just to the presenting behaviors, which is very much in line with the mandate of most child protection agencies. We need to stabilize these youth who are considered at risk to themselves or to someone else. But it leaves us with little information regarding how best to intervene and treat the behaviors and mental health symptoms of these youth. And just, in addition to the externalizing and internalizing problems many of these youth in group care have experienced, we've seen that there's quite a bit of impact on their neurological development, and that many of these youth have experienced what we might describe as complex or developmental trauma, which many of you may know is really a child who was exposed early on in life to multiple and enduring interpersonal trauma. Usually by individuals they're supposed to trust, and so this can have quite significant impacts on youth as they develop. So we know that youth in group care show higher symptom levels and fewer adaptive behaviors than those treated outside of care, and Christine referred to that as well, and that if we don't treat these symptoms or these maltreatment problems, this can lead to severe problems in later life. And many of you may be familiar with the ACE study by Anda and Filidi, which really confirmed that the higher the adverse childhood experience an adult had experienced, So the higher number of adverse child experiences, the higher their later mental and physical health problems. And this can have neurobiologic impacts, as I mentioned, on brain development. So that's impacting the body's stress and hormonal responses, psychosocial impacts such as their ability to socialize, their attachment, and as Christine was talking about, some health risk behaviors and violence, and as Sherry will be talking about, substance abuse and other risk behaviors. And so my work is informed, and I think most of our work is informed by theories of trauma, attachment and development, and in particular, I really like how John Briere sees the behaviors that these youth exhibit externally and internally, these very risky behaviors, as adaptive. It's really the youth's ways to manage the overwhelming feelings related to their experiences. And this is their way of, in some cases, even surviving. And so although we absolutely need to address these risky behaviors, I think it's really important for us to understand where these behaviors come from. And one point that I just wanted to make is that youth are very rarely invited to share their experiences, and so I think it's so important that Dr. Weckerly went to the youth themselves. We did a similar study in Quebec, a pilot study with youth in residential care, and we asked them to tell us what happened to them. So not necessarily just from the perspectives of their workers or from other health professionals or their parents, but from the youth themselves. And what I've been able to look into as part of my PhD studies is the fact that research has been clearly showing that we're kind of afraid to ask kids what's happened to them, and I think it's our fear that we may re-traumatize, stigmatize, or further harm these children and youth. And what the research has demonstrated is that this is simply not the case. While there may be some shorter term sort of distress symptoms, very rarely do kids feel that they've been re-traumatized, that they feel that they've been harmed, or that they feel stigmatized. In fact, by not asking, we're probably contributing to this stigmatization in the way that we're showing children and youth that these are questions that we shouldn't be asking them. And so, as I mentioned earlier, when we don't ask these kids, we end up over-relying on official incident statistics. And so I won't get into too much detail about the MAP study. Christine talked about it, but just to let you know that this particular, I just missed a slide here, I'm sorry. I didn't talk about resilience capacities, which does tend to be tagged on, which is what I'm doing right now. Building resiliency is an identified goal in trauma treatment and therapeutic milieux. We don't always focus on it as much as we should. We need to view youth in light of their capacities and their potential. And sometimes this is really hard. It's hard to see this due to the types of experiences they've had. And so it's really up to us to really push, and as I mentioned earlier, to really work to building this very dynamic resilience capacities that these youth have. So in terms of the MAP study, for my portion of the study, I looked at 122 youth who identified as being in group care. Of the, I believe it was 561 in total. And as I mentioned, I was looking at the traumatic experiences, the traumatic reactions, and the interpersonal competencies of these youth. And what I wanted to do was look at these youth at baseline, 6 months later, and then 18 months later, just to get a sense of how their profiles were changing over time. Although the study does go to 3 years, it's not surprising that very few of the youth who were present at baseline in group care could be reached at the 3-year mark. And so I went as far as 18 months. And so my research questions were, what is the prevalence and severity of traumatic events youth have experienced? And what is the prevalence and severity of their traumatic reactions, both at baseline and then 6 and 18 months later, as well as what do their interpersonal competencies look like at baseline, 6 and 18 months later. And so just to give you a very quick look at the demographics, as I mentioned, we had 122 participants. About 45% were female. The average age was between 15 and 16. And of course, at baseline, 100% of these youth were in group care, and that dropped as we went across the study. The average length of time involved with the Child Protection Agency, Children's Aid Society, was almost 5 years. So that's a fairly significant amount of time for these youth. The average number of moves over the past 5 years was almost 3, as well as the average number of workers. And so these kids have had at least a couple of moves. We can see here in terms of ranges, some of these kids have moved 5 times and had up to 10 workers. Okay, so in terms of looking at youth traumatic experiences, what we looked at was the Childhood Trauma Questionnaire, which basically looks at 5 types of childhood trauma, which includes emotional abuse, physical abuse, sexual abuse, emotional neglect, and physical neglect. And this scale looks not only at the types of maltreatment, but also the severity ranges, so from none all the way to extreme. So what we found was very high levels of youth traumatic experiences from the low to extreme range. We can see here that 64% of the youth experienced emotional abuse, 55% physical abuse, more than a third sexual abuse, and it's important to mention 64% of those were females, I believe. Emotional neglect, 74%. And over half had been physically neglected. And what's really interesting to look at is that maltreatment, not only was maltreatment reported by a significant proportion of the youth, but if we look at the number of different types of victimizations they had, so co-occurring different types of maltreatment, we can see that if you look down to the 4 and 5 victimization range, we had a significant proportion of youth who we would consider polyvictimized. And this basically just shows the rates of maltreatment, but also in terms of the severity levels. So we can see here that if you're looking in the severe to extreme range, we have a really large proportion of youth, close to around a third for all types of experiences had reported in the severe to extreme range. And then if you look at the far right in terms of significance, it was significant in terms of gender for females, for emotional abuse, and sexual abuse. And I think this is probably not that surprising for most people who understand that females tend to react to these types of maltreatment quite a bit more strongly. So in terms of youth traumatic reactions, we use the Trauma Symptom Checklist for Children, which measures anxiety, depression, anger, post-traumatic stress, and dissociation. And also looks at these symptoms in the range of non-clinical all the way to clinical, so when we should be highly concerned. And so if you look here, you can see that approximately 1/5 of all youth showed subclinical or clinical levels of concerns in all trauma symptom areas. So this is a great concern. And I think it is important to pay attention to youth reported in the subclinical range, because it really does highlight the need to pay attention to some symptoms that may end up becoming more severe. And just in terms of the significance of the relationships between the traumatic events these youth had experienced, so the type of maltreatment, with the traumatic symptoms, we can see that for emotional abuse and for sexual abuse, all of the relationships with the traumatic symptoms were significant except for anger. And so for anxiety, depression, post-traumatic stress, and dissociation, these were all highly significant. So just in terms of giving you a look at how this looked over time, so we talked about the baseline 6 months and 18 months measure. What we see is, happily, all symptoms decreased over the 18-month period from a 13 to 30%. And we see the largest decrease with anger, which actually decreased significantly, 30%. And so this was very positive for us to observe. And in terms, this is just sort of a different way of looking at the results, but we can see that all the clinical levels decreased except for depression, but still their overall mean scale scores decreased over the 18-month period. So now we'll look at interpersonal competency. And so for this particular measure, we use the Interpersonal Competency Questionnaire. And this particular questionnaire focuses mostly on peer competence. And so there were 4 areas that were measured. One was the youth's ability to assert displeasure, how they share their feelings and emotions with others, their ability to provide support to others, as well as their ability to manage conflict. And so what we see here is that it was really disappointing, actually. Over time, there was very, very negligible change, and this is really contrary to my hypothesis. And so I'm not quite sure how to explain it, except to say that perhaps it's that this type of resilience is but one of many resilience factors. So this is related solely to interpersonal competencies. Unfortunately, there is also a very good measure, the child and youth resiliency measures, that was administered to youth, but not until a bit later in the study. And so I wasn't able to look at this one, but I will be looking into that further for my final dissertation. So we'll see what those results hold. And so in terms of correlations, I'll just quickly run through them. Not surprisingly, with the results we saw, there was no significant correlation between the overall trauma scale scores and the interpersonal competency scores, as well as the trauma symptom total scores and the interpersonal competency total scores. Length of time in child protection was highly significantly correlated with physical neglect. So these are youth that were obviously spending a lot more time in care. Moves in the past 5 years was highly significantly negatively correlated with sexual abuse. So these kids tended to remain in more stable environments. And of course, unsurprisingly, the length of time a child was in Children's Aid Society and the number of moves in 5 years was significantly correlated with the number of workers that they'd had. And we know that this can have a real effect on workers, and on youth. And those of us who are workers know how terrible it felt sometimes to pass our file on to another worker. It's really hard for these youth to adjust. So some takeaway messages regarding gender. Well, females had higher mean scores on all subscales. So for all of the 3 questionnaires I looked at, they all scored higher. And gender was significant for all total scale scores, so for their trauma symptoms, for their trauma experiences, and for their competence. And gender was significantly associated with emotional abuse, sexual abuse, anxiety, depression, anger, post-traumatic stress, and emotional support. So the question is whether males are maltreated at lower rates. Are they less symptomatic, or are they underreporting? And so this is something that definitely should be looked into further. So other takeaway messages, overall youth reported much higher levels of traumatic experiences and symptoms than found in youth in the general population. And also this is quite consistent with literature that shows these youth tend to report higher levels than kids in foster care. For both females and males, but I do want to make a point. The Ontario Health study that Christine referred to earlier actually showed a lot of these youth were doing less well than the kids in the MAP study who were placed in care. And so this also tells us, as we saw, that exposure to the group care system may actually have some positive effects on youth as compared to kids who had child welfare involvement in the past, but who aren't currently in group care. So for both females and males, experiences of emotional and sexual abuse were significantly associated with internalizing symptoms. As I mentioned, traumatic symptoms did decrease over the 18th-month period, and this is regardless of the date of entry into care. So these kids weren't, of course, it would be almost impossible to find a group of kids who come in at exactly the same time. And so these kids came in at varying times, yet regardless, it still showed that time had a positive impact on their traumatic symptom levels. So whether this is due to maturation, whether this is due to the system, is unclear. And as I mentioned, interpersonal competency levels, although lower than youth in the general population, remained quite stable over time. And some takeaway messages. Well, as I mentioned, youth perspectives are very essential if we're really to understand their experiences and be able to actually link them to how they're doing currently and build their resilience. Our findings really support the need to conduct regular trauma-informed strengths-based assessments in child protection. So really heeding the advice of various trauma and mental health organizations to implement these standardized protocols, to develop and implement flexible trauma-informed interventions. So I'm currently working with an intervention called Attachment, Self-Regulation, Competency. And what I like about this, not only is that it's trauma-informed, but it actually also asks educators, foster parents, to reflect on their own attachment styles and their own triggers, and you know, those of us who've been workers know sometimes that often the way that we respond to youth can really impact the way that the youth behave and whether they get better, and we need to take some responsibility for this as well. And so in terms of future research, my dissertation research, I really hope to be able to develop very clear profiles of these youth at baseline, and to compare these with other youth involved with child protection services, and also to do longitudinal analysis using other measures that, as Christine mentioned, are part of this very rich data set. So in terms of general future research, we definitely need to do more longitudinal studies and see if there's any way for us to follow up post-child protection involvement as far along as we can. We do know that kids tend to do better aftercare for short periods until they return to their families of origin, and then they tend to regress a little bit. And so it's important for us to continue following these children into adulthood. And a major piece that would be relevant for everyone is our need to intervene earlier. We know that most maltreatment happens to younger children, and we know that the earlier the onset, the more negative the outcomes. And so for us to really pay attention to these kids when they're little, and to have in our minds that the youth that I'm describing today may be the little ones we're seeing in the ER or in different acute care organizations. So strengths, as Chris mentioned, this is a randomly sampled study, which definitely adds credibility to the study, self-reports, and it's longitudinal, which is very rare, and as Chris mentioned, the first longitudinal study in Canada. Some of the limitations were, as Chris mentioned, the exclusion of youth with severe problems. Of course, it makes sense that we had to exclude some of these youth. It also means that we're missing a big group of kids who we would see with some of the more severe problems. Many gatekeepers are involved in this process. We all know how difficult it can be to actually finally reach that youth to participate in the study. We always have some potential underreporting. And as I mentioned, the kids started at different times, so the measures aren't completely accurate in terms of following them longitudinally. And there were quite a few missing responses. But otherwise, I think this study really provides a lot of information, a lot of rich information for us to work from. So thank you very much for your attention today. I appreciate it.
All right, thank you, Lise. And once again, just a reminder, type in any questions into the question box if you think of any for Lise. Chris, we did have a couple of questions before we hand over to Sherry. We did have a couple of questions that came in right at the end of your presentation. That while Sherry's getting set, we might as well take a couple of these. Sure. The first question was, she was just asking if you can provide references to the research that you mentioned that Indigenous youth respond positively to cultural engagement interventions. Do you have any references that you can either share with, and we can always share these on the Knowledge Exchange Network if you have links?
Yes, that is a recent article by Dr. Christopher Mushquash, who has worked with Dr. Sherry Stewart as well, and I can, as we go on, search for that article and put it on the tweet.
Sounds good. Yep, and we'll pull it off there, and then we'll put it on the Knowledge Exchange Network as well. So there'll be lots of opportunities to get that. And the second question was during the map, the video at the beginning, it says that youth were not in their home, or youth that were not in their home of family of origin have less violence in relationships, and that positive relationships and role models help reduce violence in relationships. She felt the way that this was presented, it's a bit concerning in that it might support social workers to remove children and or not support the youth's relationship with the family of origin. Can you comment on that?
Yeah, the MAP study was not in terms of an intervention, it just was observing what was going on. And so it was the youth who were in foster care or who were in, in a cared situation. The fact was that they just reported lower levels of dating violence. Now, what that was about, maybe it was just a kind of a side factor for being more monitored and having more services brought to bear to you. So it's not necessarily out of home, but maybe it could be more services, more monitored, that sort of thing. And so anything from the MAP study doesn't really identify for child welfare services that, out of home should be a good thing to do. It's really just an idea that they should dig deeper into their different populations and see what's critical for them for reducing dating violence. And I think interventions, there are existing the Youth Relationships Project interventions that are effective. So that's really more, I think, the thinking of how that should be regarded.
Much. And again, if anyone does have any other questions, we'll be sure to get those at the next break. And for now, we're going to head out to the East Coast to Nova Scotia with Dr. Sherry Stewart. Over to you.
Thanks very much, Doug. I appreciate you hosting this, and I also wanted to thank Dr. Weckerly for inviting me to take part. And I've been very appreciative to be involved with the MAP study over the years with different projects that we've done together. My focus is in the area of substance use disorders and youth risk for various types of substance use problems, including alcohol. And today we are going to be focusing in on problem drinking amongst adolescents in the MAP study. And I should just mention from the beginning that prior to doing this work, Chris and her colleagues had taken a look at some of the substance use statistics within the MAP data set. And for example, she had shown, like, with exactly the same measures being used in the MAP study and also in regular population surveys with kids in high school, and being able to directly compare those measures and showing that rates of alcohol problems were higher amongst children or the adolescents in the MAP study. So this is an important topic to talk about today. So I'm going to talk about two different studies, and in both of those studies we'll be looking at aspects of child maltreatment and its relationship to problem drinking in the MAP sample. And in the first study, we're going to be looking at some sex-specific emotional pathways that might explain the links of specifically childhood sexual abuse to problem drinking in this population. And in the second study, we're going to look at something called a chain mediation model, where we're looking at two different potential mediators that unfold over time to explain the broader link of childhood maltreatment to problem drinking in this sample. And we'll look in at clinical implications and the idea of tailored treatments toward the end. So the first study, as I mentioned, is about sex-specific pathways from childhood sexual abuse to problem drinking. And this is something that the first author on this paper that we've recently submitted is my postdoctoral fellow, Amanda Hudson, who wished that she could be here today, but she's actually teaching at this time, as well as some of our other colleagues, Chris Weckerly, as well as Abby Goldstein in Toronto, Stephen Ellenbogen at Memorial, and a number of other collaborators. So we do know, we've heard already today about how childhood maltreatment is associated with a number of different negative outcomes. And this project focuses in specifically on one type of childhood maltreatment, specifically sexual abuse. And we do know that childhood sexual abuse has links to a number of different negative outcomes in adolescence and adulthood, like earlier initiation of illicit drug use, polysubstance use using a number of different drugs, which can be quite risky, risk of fatal overdose, increased use of alcohol, as well as risk for alcohol use disorder. So there have been a number of studies out there, and this is quite well established. So this study is really trying to understand a little better why this link occurs. So what are the mechanisms involved in linking childhood sexual abuse to later alcohol problems in adolescence? And we do know that a large proportion of people who have experienced childhood sexual abuse experience different types of emotional dysregulation, and this can be both more internalizing types of symptoms as well as externalizing, so both depression and anxiety on the more internalizing spectrum, as well as more angry reactions on the more externalizing spectrum. And we also know from a few different studies that maltreatment is linked to alcohol problems through emotional symptoms. So there have been a few different studies that have taken a look at this before. So the idea being that kids who have maltreated or who have experienced violence, that they tend to show these emotional symptoms, and that they may be trying to manage these emotional symptoms, and that leads them into developing problems with alcohol. So the idea of self-medication. Now, the current study wanted to better understand the links between childhood sexual abuse and alcohol problems in a riskier sample, a more vulnerable sample, where we know they've had a number of those experiences, many of the sample. And we wanted to look at emotion symptoms as mediators, as potential explanatory variables in linking childhood sexual abuse to alcohol problems. Another thing we wanted to do, Lise spoke in her talk about the importance of gender, and here we wanted to also take a look at gender as a potential moderator, because there has been some work showing that while girls are more likely to experience anxiety and depression, more kind of internalizing symptoms in response to victimization experiences like childhood sexual abuse, that anger is a common reaction more from boys. So we wanted to see whether it might be that depression and anxiety mediate the childhood sexual abuse alcohol problems relationship more in girls, whereas anger reactions mediate more so in boys. So the participants were a subset of participants from the MAP project, and again, you've heard about how they were randomly selected through Ontario Child Welfare Services. In the study that we did, study 1, there were 301, a little bit more girls than boys, 56% female, and on average they were about 16 years old during the study. And we used a cross-sectional design for this study, so we're just looking at the variables that were collected that were of interest to us from a single wave of the maps, of the longitudinal map study. The first measure that we used was the Childhood Experience of Violence Questionnaire, and specifically because we were interested in sexual abuse, we looked at the 6-item sexual abuse scale from the CEVQ, and this is where children rate how often they experience various types of sexual abuse experiences, and then their scores are totaled. And what you can see here is a repeat of what you've heard already from Lise, that girls are more likely to experience more severe sexual abuse than boys. So we see that being replicated here. We also used the trauma symptom checklist for children that was developed by John Briere, and this looks at different types of emotional symptom, well, a variety of different types of symptomatology. And since our focus in this study was on emotional symptoms, we looked at the anxiety, depression, and anger scales from that measure, which has 6 scales altogether. And as you can see here, anxiety and depression was more prevalent amongst the girls than the boys. We didn't see higher levels of anger in the boys, which we might have expected. Actually, there were no gender differences in our subsample on anger. Then we also looked at the Rutgers Alcohol Problem Index, or the RAPI, which is a measure of alcohol-related problems that that is really designed for use in adolescents and young adults. So it's the kind of experiences like missing school due to being hungover, those kind of things that can happen more often in younger people, or getting into fights with friends or with family. And as you can see here, so first people report on the frequency in which they've experienced those symptoms in the past month, from never to 4 or more, or 10 or more times, which is scored as 4. And when you add those scores up, you can see that we didn't have significantly higher scores in men than women in the sample, or boys than girls in the sample. You usually see higher rates in males than females, but we actually got fairly high scores in both the boys and the girls. Now, moving on to the results, what you can see here is a mediational diagram. So this is just for the males, and the reason that we separated it out by males and females is that when we ran the model for the whole sample and checked whether there were gender differences, there were significant gender differences. So as we expected, the mediational pathways differ for boys and girls. So we're going to start off with looking at what happened for the boys. And first of all, you can see that greater levels of childhood sexual abuse on the CEVQ for the boys was related to higher levels of anger, anxiety, and depression. So that's over on the left-hand side of the screen. You can see that. You can also see that there's a relationship between childhood sexual abuse and drinking problems, which we were expecting to see. But we do see only one mediational relationship, and that is through anger. So as we had expected, the boys who experience more severe childhood sexual abuse are experiencing higher levels of anger, and higher levels of anger in turn are related to greater problem drinking in the boys. The other thing that you notice is in the middle line is that even when we've accounted for anger, we still see a relationship between childhood sexual abuse and problem drinking. So that means that anger is only partially mediating or partially explaining why childhood sexual abuse is linked to problem drinking in boys. So this means that we need to do more research to find out what other factors might be helping explain this relationship other than anger reactions. Now we move on to what happened with the girls. Again, we see with the girls, as we did with the boys, that more severe childhood sexual abuse is linked to anger, to anxiety, and to depression. So this is just what we saw in the boys, but the mediational pathways differed. If we look more towards the center, we see that, as we had expected, greater levels of childhood sexual abuse were linked to greater levels of anxiety, and greater levels of anxiety were related to greater problem drinking. So it does seem that there's a pathway by which girls who have been sexually abused have more anxiety-related symptoms, and they may be trying to deal with those anxiety symptoms through drinking, and that drinking becomes a problem for them. So that we had expected. However, we also saw a significant mediational pathway through anger for the girls, which wasn't expected. So just like the boys, there's also a pathway where the girls who have had greater childhood sexual abuse experiences are experiencing more anger, and in turn that anger is explaining why they develop problems with alcohol. The other thing, two more things I want to note. One is that we didn't get the expected relationship with depression. This tells us that we know that anxiety and depression are highly correlated, and it's really, for the internalizing symptoms, it's really the anxiety that the girls are dealing with through drinking rather than depression. But why wouldn't depression be a mediator? And in fact, you can see the negative number over on the far right, the negative 0.23 with a little cross beside it. This is kind of suggesting that depression may be more protective, which sounds very funny. Why would that be? And one possibility is that's what's happening is when girls who are depressed, they may be more socially withdrawn and just not in the kind of circumstances, the party circumstances where alcohol is being served and so on. So it's not really that depression's protective, it's just that they're not getting into those situations where drinking is taking place. Now, in terms of childhood sexual abuse having any direct relationship to problem drinking, the middle line is not significant. So after we account for these emotional factors, we fully explain why childhood sexual abuse is linked to problem drinking amongst the girls, whereas we didn't see that for the boys. So it seems to be a more around emotional reactions for girls than it is for boys in terms of wholly explaining this relationship. So just to review, emotion symptoms pertinent for predicting problem drinking in girls were both anxiety, as we had expected, as well as anger. And the only emotion symptom was anger that was important in explaining the relationship of childhood sexual abuse to alcohol problems in the boys. The emotion symptoms were full mediators in females, so explained the whole relationship, but it only partially explained in males. So it might be that it's a more complex relationship in males and that we need to search for additional mediators. Moving on to our second study. So this is one that we have in process, and we're just writing it up right at the moment. And again, it was conducted in collaboration with Amanda Hudson, Kara Thompson, who was my former postdoc, who's now at St. FX, as well as Chris Weckerly. So we're moving more broadly to talking about both abuse and neglect experiences, and physical abuse as well as sexual abuse, emotional abuse. And we know that together those types of experiences have a myriad of negative consequences. So they're associated with school dropout, with perpetration of violence. They're also associated with two things that we want to focus in on with this study. So internalizing symptoms like post-traumatic stress disorder. So here we're talking about an emotional reaction to trauma that involves a variety of types of specific symptoms. So one of those is re-experiencing. So that's when a young person has traumatic, intrusive memories about the trauma, or feeling as if the trauma is happening, so a re-experiencing phenomena where they feel like they're going through the experience again. Or nightmares can also involve physiological hyperarousal, like being very easily startled. It can also involve avoiding experiences, reminders of the trauma. So Dr. Weckerly earlier mentioned if somebody had been sexually assaulted in a basement, avoiding basements in the future, that would be an example. Also emotional numbing. So when a young person feels very emotionally numb following the experience. We also know that childhood maltreatment is associated with alcohol and other drug misuse, and it's really this alcohol problems that we're trying to understand with this study. So we know that childhood maltreatment is associated with alcohol misuse, but what are the potential mechanisms? And we do know that a variety of studies have looked into PTSD as a possible explanatory factor. We know that it's a possible negative outcome of child maltreatment experiences. And in one study that I actually did with a former graduate student, Mark Zaradnik, in collaboration with Chris Weckerly, it was done with a sample of First Nations adolescents, and we found that greater childhood maltreatment experiences were associated with greater post-traumatic stress symptoms, and that post-traumatic stress symptoms explain the relationship between childhood maltreatment and alcohol problems, as if the young people are using alcohol to try to self-medicate for their post-traumatic stress symptoms. And it was specifically PTSD hyperarousal that helped explain that relationship in that study with First Nations adolescents. Another potential explanatory factor, mediating variable, are drinking motives. Cooper's developed a model to explain why young people drink, and she says we should take a look at what are the outcomes that the young person is trying to achieve when they drink, when we try to classify or categorize different reasons for drinking. So she says we can think about the valence, we can think about positive reinforcing reasons for drinking and negatively reinforcing reasons, so positive adding in something desirable or negative reinforcement getting away from something aversive. And along the the left, you can also see that we can classify drinking motives as internal or external. Is the person trying to change something within themselves, or are they trying to change something in their external social environment? And when we cross those two dimensions, we end up with 4 different reasons why young people might drink. They might drink to enhance, for the high or the rush or the buzz. They might drink to socialize, to celebrate a special occasion with their friends. They might also drink to fit in with peers, drink for conformity reasons, so that they reduce the likelihood of social censure for not drinking. And importantly, for our purposes today, they might also drink to cope with negative emotions or to manage aversive internalizing kind of symptoms like PTSD. And why it's important, why I end up talking about coping motives, is that lots of research has linked different motives to different patterns of drinking and different outcomes. And the motive that's most closely linked to alcohol-related problems is drinking to cope. So we wanted to take a look at coping motives as another potential mediator in explaining the relationship between childhood maltreatment and alcohol problems in the MAP study. So our objective was to better understand the links between childhood maltreatment and alcohol problems in the MAP participants. We wanted to examine both PTSD symptoms and coping-related drinking motives as potential mediators. And we wanted to introduce and test a model that's been sort of out there more implicitly for a while, which is a chain mediation model that talks about one mediator leading to the next mediator leading to the outcome. So the idea is that childhood maltreatment could give rise to post-traumatic stress symptoms, and that those post-traumatic stress symptoms are aversive and might lead somebody to start drinking to cope. And as they're drinking for that maladaptive reason, that in turn gets them in trouble with alcohol. So it leads to alcohol-related problems. So the participants in this study, again, were a subset of participants from the MAP project, 568 of them, just over half of them women, and again, around 16 years old at the baseline. We made use of the longitudinal nature of the data by using a pseudo-longitudinal design, so 2 waves of data collection over 6 months, with 74% retention over the two waves. The measure that we used has already been described by Lise, the Childhood Trauma Questionnaire. So we used a total score on that scale. So that's really looking at physical, emotional, and sexual abuse, as well as neglect experiences. And trauma symptom checklist. We've already talked about that, but we looked at the PTSD scale in particular on that measure. And it's a measure that's very suitable for assessing PTSD in children and adolescents. To assess coping drinking motives, we used this coping subscale from the Drinking Motives Questionnaire revised, and this was administered at both waves 1 and 2. So an example item might be to forget about your problems, drinking to forget about your problems, and they indicate how often they do that. And then the Rutgers Alcohol Problem Index. For study 1, this was the same outcome measure, so I'm not going to go into it. And it was administered at both waves 1 and 2. Now here's our model. So at time 1, we have our childhood trauma scale and our PTSD scale. And at time 2, we have our drinking to cope measure and our alcohol problems measure. Overall, this chain mediation model fit the data very well, and we also got evidence for chain mediation. So we can see here over on the left-hand side that childhood trauma is linked to post-traumatic stress symptoms at time 1. So having greater experiences of childhood trauma is related to more post-traumatic stress symptoms. And then post-traumatic stress symptoms, even when we account for baseline levels of drinking to cope and alcohol problems, is linked to more drinking to cope at time 2. So that's really like escalations in drinking to cope over time. And the more somebody was drinking to cope at time 2, the more they were experiencing alcohol-related problems. And we can also see that the relationship between childhood trauma and alcohol problems at time 2 is non-significant. So that tells us that this mediational pathway fully explains the link of childhood trauma to later alcohol problems. We also tested single mediator. So could we explain the link of childhood trauma to later alcohol problems by just PTSD without considering drinking to cope? And we couldn't. So either of the single mediator models didn't fully explain, wasn't significant. So we needed both mediators in the model to have a good model. So just to review, PTSD symptoms do seem to be pertinent for explaining the relationship of maltreatment in childhood to problem drinking in adolescence in the MAP study. So that extends the work we already did with First Nations youth and extends it to youth in Child Protective Services. And the idea that maltreatment survivors are drinking to deal with post-traumatic stress is this is really the first time we've seen evidence of that because it's shown through their further mediation by drinking to cope. And the fact that we see both mediators being necessary for mediation suggests that it's more complex than either just drinking to cope or just post-traumatic stress alone. And it's suggesting really a pathway that's unfolding over time. Now, some of the limitations of the studies, of both studies, issues with retrospective self-reports of childhood sexual abuse, so maybe there's unwillingness to disclose, we're relying on accurate memory. However, probably in that respect, we've got better data than we would by just virtue of what's in the records, because this is according to the children themselves. And in terms of self-reports of alcohol use, there's some potential accuracy issues, especially in youth, but there's ways to get more accurate information that were used in this study, like assurance of confidentiality and so on. In terms of study 1, gender norms could influence the self-reported emotional symptoms. So it's more acceptable, likely, for girls to admit to experiencing internalizing symptoms like anxiety and depression, and that might account for some of the elevations that we see in girls there. Cross-sectional data was used in study 1, so we really can't infer causality. And in study 2, we're getting a little closer because we used that pseudo-longitudinal design, but unfortunately we just have the 2 waves of data to work with as opposed to the optimal 4 for really looking at a true longitudinal picture of this process unfolding over time. So in terms of implications, what do these studies mean for targeting interventions for children who are receiving child welfare services? First of all, both studies really point to the importance of screening for childhood sexual abuse or maltreatment more generally. And they point to potential targets for tailored interventions, emotion symptoms in study 1 and PTSD symptoms and drinking to cope in study 2. Study 1 really suggests the importance of a gendered approach, so that boys may need different services than girls needing attention to anxiety if they've experienced childhood sexual abuse, and both genders requiring attention to anger reactions. And study 2 really suggests the need to focus on both mediators, PTSD and drinking to cope, if you've got somebody who already is showing symptoms of problem drinking. But in terms of earlier intervention, if somebody's had a childhood maltreatment experience, focusing in on their post-traumatic stress symptoms might be a way of preventing the development of drinking to cope and ultimately of alcohol problems. So what kinds of strategies can we use? We've heard about trauma-informed care. That's very important. Teaching young people who've been through these experiences negative affect management skills. In terms of PTSD, there are a number of different empirically supported interventions. CBT is a very good one. And motivation-matched interventions for substance misuse. I just wanted to mention that because we have done some work looking in at kids who drink for different reasons and trying to tailor our interventions to those underlying reasons and patterns and teaching individualized coping skills. So somebody is using alcohol to cope with negative emotions, teaching them better emotion management strategies can be very helpful, and that they have very different needs from somebody who's drinking to cope, drinking to enhance positive mood states, for example, or drinking to fit in. And there's evidence of the effectiveness of that approach, and I'll just refer people to the work that I've done with Patricia Conrad, and really showing very good effectiveness of delivery of those types of matched interventions. And I just want to acknowledge all the people involved in the MAP collaboration and all the organizations involved, as well as the organizations involved in funding the projects that I've spoken about today. Thank you very much.
All right, thank you. And we did have a number of questions come in. The first questions from Paul were related to when you first put up the pathways relating abuse and problem drinking, and you had the 3 mediators of anger, anxiety, and depression. He was just wondering if there's a similar relation to drug abuse as opposed to alcohol abuse, or if that was even part of the study.
It wasn't part of the study, and it's a great idea, and we can do it. We have not done it yet, but we could do that.
Okay.
Very great idea. And we don't have, I shouldn't say that, we don't have like a long standardized measure of drug-related problems. We have lots of really good data on use of different drugs in the MAP data set, and there are some items that we can probably pull out that we would be able to look at that, but not as well as we might with the full RAPI. But certainly we could look at its relationship to drug use.
Right.
We'd have very good data for doing that.
Okay. And he's also suggesting a related question or a related issue might be the alleged, what he suggests is the alleged overprescribing of prescription medication and how that might affect the relationship with drug abuse and wondering if that could be part of future research as well. But.
Yeah, that's a great idea. So are you you're suggesting that like as an outcome or as a potential moderator of the relationships that we saw?
I will have to ask Paul if he can put in a follow-up comment about that if he's suggesting that as an outcome.
Anyway, I think both of those would be interesting ideas.
All right. The next question is coming in from someone who identifies himself as an adult female of a mother who has documented prenatal alcohol abuse and is one of the many adults living today who survived neglect and abuse, etc. She's wondering if there have ever been any studies involving the adult population who are using or have used maladaptive behaviors as coping mechanisms, and just wondering if those adults who did not receive adequate interventions during their youth, if there are resources or research in the area of the benefits of getting interventions now as an adult.
That's a great question. One of the studies that kind of went into informing the PTSD study was with adult women. So that was and they found the same kind of relationship with PTSD symptoms, explaining the relationship between like earlier victimization experiences and alcohol-related problems. And I don't know the answer to the question about intervention, like whether when somebody got adequate intervention when they were younger, did that kind of prevent the unfolding of that kind of causal pathway. I don't know that there's research out there. That's a great question, and we would hope that it would. I'm just going to open that to Chris. Chris, you don't know of any research that's looked at like intervention as a moderator?
Well, I think that maybe the important point is that recognizing that if you've had layers of trauma, intergenerational trauma, institutional trauma, cultural related traumas, that it's important. It's good self-care to be able to understand those trauma symptoms with a professional, and then go from there as to what might be supportive. I'm going to search on to see what studies there are about that, but I think that's sort of, the idea that there's always capacity to increase resilience, and, I think that we're clear that the brain has plasticity, and what you do more practice on is what gets connected and what gets reinforced. So I think that taking that resilience focus is also an important sort of strategy approach.
Yeah, and maybe I'll just add in that and if somebody didn't receive the services they needed when they were younger and they end up in adulthood with both problems, like both post-traumatic stress and a substance use problem, there's now research coming out about interventions that try to target an integrated approach for working with both types of problems simultaneously. So one example is Lisa Najavit's Seeking Safety, and that one is very much a resilience-based approach. It includes cognitive behavioral skills, but it's also quite focused on resilience building, as the title might suggest.
Yeah. All right. We just had a comment coming that says Manitoba no longer has an FASD diagnostic process, and just commenting on what happens to adults today who are in the wind, they say, so to speak, and where they might seek help with these sorts of issues. But we are just about out of time, and we did have one more poll question. We wanted to go back to that first poll question just to see if there's been any change in how people value trauma-informed care based on what you've heard today. So while we're waiting for any last-minute questions to come in, we're just going to reopen this poll and just see if anything's changed. And this is just, again, your opportunity to click on the screen and put in your answer and just see how highly you value trauma-informed care. All right, we got most of the responses are coming in, and we did have another comment from Dr. Gail Andrew, who many from the Glenrose Rehab Hospital and the FASD clinic director out there, who co-hosts many of these webinars with me. She says many kids in care are overprescribed medications to treat the behaviors that are related to the trauma rather than providing the treatment for the PTSD. And she says this can lead to polypharmacy. The question of this leading to drug abuse later is a good question. Unfortunately, it's very difficult to get trauma therapy, and the MAP data should drive policy to develop this potentially.
Yeah, absolutely. I mean, trauma therapy isn't so hard to acquire training in. The trauma-focused CBT, which is used for maltreated youth, had a free online training, and that's been implemented, at least in Ontario, to my knowledge, in some of the child and family services and some of the child advocacy centers, as well as in Quebec's. You know, that is an important policy issue. We know trauma is quite pervasive, and we are understanding youth as being poly-victims, that a sizable segment of youth are have experienced poly-victimization, as it's called. Why aren't we directly targeting trauma symptoms if we're showing here that trauma is either a partial or full mediator of health risk behaviors?
All right, so we're just going to look at the results, and we had actually no change from the when we first asked the question. 92% of people highly valued, and 8% valued trauma-informed care. So we definitely have strong support for the topic. So it's sorry,
that's great, because we need advocacy on that. We need advocacy for trauma-informed care. So thank you, everyone out there, for being so invested in it.
All right. So I think we are out of time. So thanks again to Gail for such a great comment and really an interesting discussion and opportunities to move forward. And with that, maybe we'll just hand it back to our panel to see what any closing thoughts that you might have. And maybe we'll start in reverse order. We'll start with Sherry. Just see if there's any final thoughts you want to leave the audience with before we wrap up.
No, I just want to thank the audience for the questions and for the suggestions, which we will follow up with in the data set. Thank you very much.
All right, and Lise, any closing comments from you?
No, not really. I'm just so impressed to see how invested everybody is in trauma-informed care, and I like how Christine's suggesting it's not necessarily extremely complicated to reform our systems towards that end. And so again, thank you very much for your time and attention today.
All right, and Dr. Weckerly, any closing comments you'd like to leave the audience with?
I just thank you so much for being engaged. Child maltreatment is very real in kids who present to all sorts of health service entry doors. They may come in for not only to emerge, but into specialty clinics. And you know, having that sensitivity to a trauma history, I think, is really important. The MAP data set is quite a rich data set, so I just say stay tuned because there's more publications to come. If you would like to get a listing of MAP publications, do email me at chris.weckerly@gmail.com or weckerc@mcmaster.ca. I'm happy to provide a listing of MAP publications to date.
And does the MAP study have a website?
The MAP study doesn't have a public website. It had an internal website to child welfare.
All right. Well, we will definitely put your contact information on the page. So if people do want more information about the MAP study, we will certainly encourage them to contact you. All right, so thanks for a great presentation, lots of great discussion. And we did hear the term trauma-informed care numerous times. We do have, if you search on the Knowledge Exchange Network for trauma-informed care, we did have a presentation, as I mentioned, from our colleagues at the IWK Health Center about the strategy in Nova Scotia to roll trauma-informed care out across the province of Nova Scotia. So that's, if anyone's looking for at least an example of how it was done there, that might be an interesting presentation for people to watch. As I mentioned, just use the search functionality on the Ken and you can find that presentation. It may give you some ideas about how you might start implementing that in your own organization. So thanks again to Dr. Sherry Stewart, Lise Milne, and Dr. Chris Weckerly. Again, a great presentation, and thank you to our audience. We do these webinars every Wednesday at 11 a.m. Eastern Time, and it is always great when you can watch live, as those questions and comments really help out with the discussion and really help us understand what's going on in the world of children's health care and mental health and well-being. We do record these sessions, of course. If you can't watch live, or if you want to share this session with your colleagues, please direct them to the Knowledge Exchange Network and have them take a look at the session as well. Next week, our webinar will be on practical applications of social media in healthcare, titled The Good, the Bad, and the Ugly. And in this session, we're going to hear from Dr. Eric Benchamal and Ann Fuller. Dr. Benchamal is from the CHEO Research Institute, and Ann Fuller is the VP of Communications at CHEO, the Children's Hospital, to talk about their experiences as a healthcare researcher and as from the hospital perspective in using social media and what their experiences have been, the good, the bad, and the ugly there. And we're also going to hear from Rob McEwen from Argyle Communications to talk about sort of what the current strategies are in using social media, and in particular from his experience in using it in strategic campaigning as a tactic to support local and national public health initiatives. So anyone who's trying to improve their social media presence in the healthcare space shouldn't miss that one. And on April 20th, we'll hear from some of our colleagues, some work led by our colleagues at the Canadian Pediatric Society. And we're going to hear about promoting early literacy in the healthcare setting, connecting for a national strategy. And joining us will be Dr. Alison Shaw, Carol McDougall, and Jan Lariviere, who will show us that learning to read starts at birth, and we'll explore why and how we can support early literacy in the healthcare setting. So another great presentation coming up next week and the week after. So thanks again for joining us today, and we hope to see everyone back here next week. Bye, everyone.
Bye.
Bye-bye.